Good morning. This is Dr. Eric Bricker. Thank you so much for being here today. Welcome to AHealthcareZ. Welcome to the top 4 healthcare finance topics of 2022. Now, as always, let's start out with a audio and video check. In the comments, if you could please comment if you can see and or hear me, that would be great so we can confirm that. And then also too, remember that as we go through the presentation, that I encourage you to put your comments and ask questions in the comments section of either LinkedIn or YouTube, and then I'll stop periodically through the talk to answer your comments and questions. Now, thank you for the confirmation, Ryan. I appreciate it. Now, on to the top 4 healthcare finance topics of 2022. But first, very brief background about myself for those of you on the training session who are not familiar with me. So my name is Dr. Eric Bricker. I'm an internist. I actually originally started my career as a hospital finance consultant working in the billing department of major medical centers like the University of Kansas, Cleveland Clinic, Yale Associated Hospital, then went on to the University of Illinois for my MD, and then did my residency in internal medicine at Johns Hopkins because I thought I wanted to be a policy wonk, but I actually started a company during my residency. And then when I finished my residency, I went down to Dallas, where the company was, where I started. And I worked as a hospitalist physician in the beginning because we bootstrapped the company. We had no income, and so I had to make a living somehow. So I worked as a hospitalist physician, and then that company that I started was a healthcare navigation and advocacy firm called Compass Professional Health Services. And my 2 partners and I grew that business to over 2,000 employer clients, about 1.8 million people, where we would handle all of the administrative complexities that patients deal with, and people would access our service through their job. So in your job, you get your medical, dental, vision insurance, and then you get your Compass Professional Health Services as your personal healthcare concierge. And then we sold that business to Alight Solutions in 2018. And really, I worked with so many employers and HR and brokers and consultants and CEOs and CFOs around their health insurance and their health benefits and their healthcare, that I just saw that there was a real opportunity to educate the people that had budgetary control over healthcare at their businesses, to really educate them more on the nuances of how healthcare works and how there's really a lot of issues around access and quality and cost and variability. And so that's why I created AHealthcareZ, which many of you are viewers of either on LinkedIn or YouTube. I'm super appreciative of that. And of course, I'm the medical director of Simple Pay Health, which is an alternative health plan now as well. So I want to start out with a very brief review of 2022 for AHealthcareZ. So today on this call, we actually have viewers from 33 states and 3 countries. And so I'm super appreciative. I mean, I'll just name all. I'm gonna because I love how geographically diverse all of you are. So I just want to very briefly go through some of the places where all of you are viewing from. So Massachusetts, New York, North Carolina, Louisiana, Arizona, Ohio, New Jersey, California, Missouri, Florida, Pennsylvania, Georgia, Minnesota, Texas, Mississippi, New Hampshire, Colorado, Wisconsin, Arkansas, Washington, D.C., Oklahoma, Washington State, Tennessee, Michigan, Indiana, Connecticut, Virginia, South Dakota, North Dakota. That's great. We have both Dakotas. We don't always have both Dakotas on these calls. Oregon, Kansas, and Utah. And then for our international viewers, we have folks from Saudi Arabia, Egypt, and India. So welcome to everybody. I am super appreciative for all you being here. For the whole year of 2022, AHealthcareZ has had 1.3 million views of healthcare finance educational videos across LinkedIn and YouTube. Like, my kids jokingly tell me I'm the most boring YouTuber on the planet. So the fact that 1.3 million people have actually watched AHealthcareZ videos over the course of 2022 is just astounding. Never in my wildest dreams would I have ever thought that would happen. And then new for 2022, like we're doing today, I added these Friday training sessions, and we've only done 10 of them. This is the 10th one. And believe it or not, we've had 1,750 hours of training that have occurred through these Friday sessions. So this is the final training session of 2022. And then I will be back after the first of the year in 2023 to continue the training sessions. Yeah. These top 4 topics of 2022 are based upon the most viewed videos on LinkedIn and YouTube. So I went through all the videos for AHealthcareZ in the past year and which ones were the most highly viewed. And so what this means is that people were literally either searching for these topics, especially on YouTube. That's how a lot of the YouTube views happen. They go into the search bar, or 2, it just shows up on their feed, either in LinkedIn or on YouTube, and it's a particular topic of interest. Also, the view times for these videos were also much longer, so it shows a greater level of interest in these videos as well. So I wanted to share, because it gives us a little bit of insight in terms of, okay, well, what's on people's mind in the world of healthcare finance? What piques their interest? Okay, so topic number 1 is doctor pay. Now, this particular topic on doctor pay is based upon a study by the RAND think tank, which many of you are familiar with. And, oh, Jose, welcome. We've got Spain here. I certainly don't mean to leave out any of our other international guests. Now, so RAND is a think tank. Now, it also was a joint study in conjunction with Harvard researchers that was published in the Journal of the American Medical Association at the beginning of this year on January 1st of 2022. It's a really interesting study where the researchers looked at 31 physician practices that were owned by 22 separate hospital systems across the country. And just like you, that's very geographically diverse in terms of where in America these 22 hospital systems and 31 practices were. And they looked at, okay, how much of the doctor pay was based on fee-for-service patient volume versus quality-based reimbursement, or what might be referred to as value-based care. And what did they find? They found that 84% of the primary care physician pay was based on fee-for-service patient volume. 93% of specialist pay was based on fee-for-service patient volume. In other words, the more patients you saw and the more stuff you did, the more tests or procedures that you ordered or performed, the more you got paid. Now, conversely, 9% of primary care physician pay was based on quality, and only 5.3% of specialist pay was based on quality. What's that called? That's called the vast majority of doctor pay to this day in America is based on fee-for-service patient volume. The vast minority of physician pay in America is based on value and or quality. So you hear all this stuff in the media about value-based care, but just know where the rubber meets the road and where the doctors are getting their paychecks and how they are financially incentivized is based, the vast majority of it. I mean, it's like 10 times more of their income. If you're a doctor, you're like, okay, well, how do I maximize my income? Well, 10 times of the number of patients I see and the number of procedures I do is 10 times more important than the actual quality of the care I deliver in terms of my compensation. Now, this is a direct quote from the conclusion of the study. And I'm just going to go ahead and read this here. The results of this cross-sectional study suggest that primary care physicians and specialists despite receiving value-based reimbursement incentives from payers. The compensation of health system primary care physicians and specialists was dominated by volume-based incentives designed to maximize health system revenue. And I'm going to read that underlined part again. The compensation of health system primary care physician specialists was dominated by volume-based incentives designed to maximize health system revenue. I'm going to pause and let that sink in. There's nothing for me to add. That spells it all out right there. This is not some Eric Bricker comment. This is directly from the RAND Research and Development think tank and the researchers from Harvard, published in one of the most prominent medical journals in America and in the world. Okay, here is an interesting corollary that came out at about the same time at the beginning of 2022. This is from the GIST Healthcare newsletter, and GIST is a hospital consulting firm that has a Friday newsletter. If you go to gisthealthcare.com or you look up GIST Healthcare on Google and you go to their website, I highly encourage you to subscribe to their newsletter. It comes out every Friday. It is fantastic. One of the things that they have on their newsletter is where they share anonymous conversations that they have with hospital executives during the previous week in their consulting work. So because it's directly from hospital executives and because it's anonymous, it gives you a very transparent view around the thoughts and priorities and actions of hospital executives. And so this is a quote from the CEO of a hospital-owned physician group. Here's the quote. The honest answer is that we need different things from our primary care docs and specialists. If we're all in one group tied to the system, i.e. the hospital system, the pressure will always be there to maximize specialist referrals over other goals. Other goals might be like patient outcome, patient safety, preventive care. Now, note that the prior slide that talked about how primary care physician reimbursement was based upon patient volume, how does that tie into maximizing specialist referrals? Okay. When a primary care physician is incentivized to see as many patients as possible, the way for the primary care physician to save time and therefore see more patients is to not do the quote unquote workup in terms of the diagnosis and treatment on a particular patient, but it's just to refer them to a specialist. And I've talked about this before on AHealthcareZ, where there is an issue, let's say, with a patient in regards to their swallowing, refer to GI. There's an issue with their patients in regard to their sinuses, refer to ENT. There is an issue with a patient with regards to any number of issues. A skin issue, refer to dermatology. Okay. Now, the primary care physician in many situations is more than capable of diagnosing and addressing those situations. And only after they've gone through initial evaluation and treatment of that condition, and it basically doesn't work, or they've got a red flag symptom that says that, oh, hey, look, I can tell from what's happening here that this is going to need some sort of procedural, procedure to happen. And so I just need to refer you right away. However, when the physician is incentivized to maximize patient volume, it also incentivizes them to maximize specialist referrals. So that is how this corollary relates to the previous slide. And that is how hospital systems then maximize revenue, because if you give the primary care physicians as little time as possible with their patients, then they refer to the specialist, and the specialists, as part of their diagnosis and treatment workup, are much more test and procedure intensive. So that is the flywheel that then generates hospital revenue. So, take home point for this. Charlie Munger, vice chairman of Berkshire Hathaway, many of you know who he is, Warren Buffett's right-hand man. He said, incentives are superpowers. Now, I added in brackets the word doctor. He didn't literally say doctor, but I'm adding the word doctor. Doctor incentives are superpowers. I'm going to tell you a quick anecdote. So when I was working as a hospitalist, they were talking about our small group of hospitalists. There was only 7 of us. Yeah, 7 of us. They were talking about changing our compensation so that we would get $100 for every admission that we did, because admissions are a lot of work. So they're like, okay, well, we'll just give you an extra $100 for every admission you do, because if you have a shift, we would do 12-hour shifts, 7 to 7. And if you did a lot of admissions during that 7-hour shift, well, then that was just a lot of work during that 7-hour shift. So they're like, okay, well, we'll give you an extra $100 for every admission. So one of my fellow hospitalists said, okay, well, if you're going to pay me $100 for every admission, then I'm going to go down to the ER and I'm going to sit there the entire time. And I'm going to encourage the ER physician to admit as many patients as possible from the ER. So now typically the hospitalists do not, quote unquote, encourage the ER doctors to admit patients. So just know that does pay change people's behavior? Yes. Are physicians people? Yes. Therefore, physician pay will change physician behavior. All right. Next quote from Andrew Carnegie. Don't listen to what people say. Watch what they do. Okay. Now I'm adding in brackets here. Don't listen to what people say about value-based care. Watch what they do. So there's gobs and gobs of information and stories and media hype around value-based care. But just know that where the rubber meets the road in terms of how the money is actually being transacted, how the money is actually being handed to people, the vast, vast, vast majority, 10 times more, is through fee-for-service patient volume and not through value-based care. Okay, next up. PBM money flow. Let me stop here for a question from Lee. Thank you, Lee, for your question. If anybody else has any questions, please feel free to write them in. Do you think the motivation of the MD changes with time in career, i.e., the young doctor has greater focus on maximizing income to pay loans? Do you think a near retirement MD is more patient-centric? That's a great question. And I can just tell you that in my observations, it has not necessarily correlated with their point in their career. Again, that's just based on my observations. There are absolutely older physicians who are highly money focused. And because what happens is that it really is based upon their lifestyle. Frankly, there's just a lot of doctors that have very expensive lifestyles. And so if they're an older physician, they might still need a lot of income because they just have a lavish lifestyle. There's a very interesting book about this. Many of you are familiar with it, where it's called The Millionaire Next Door. And they looked at the millionaires in America, and they actually found that doctors were actually not a part of a lot of those millionaires in America, while doctors make much more than the average American. So why is it that doctors would have such high incomes yet not be millionaires? Why were they not accumulators of wealth? And the reason is because doctors spend a lot. And obviously that's a generalization. There's a lot of doctors that don't. But I will tell you that probably one of the reasons for that, in my opinion, is that because from a financial standpoint, doctors have so much delayed gratification, essentially for their entire decade of their 20s and into their 30s. And they frankly, once they have some income, they kind of go nuts, and they try to make up for the fact that they worked so hard and had so little money for so long. And they buy the big house and they buy the fancy cars and they go on the fancy vacations. And listen, I'm not judging them for that. Listen, if you want to buy a fancy car, live in a fancy house, and go on a fancy vacation, listen, that is your prerogative. I mean, this is America. It's a free country. I'm just saying that that's expensive. And it ends up putting you in a position where you just haven't accumulated a lot of savings when you end up doing that. The last point I'll say on this is, honestly, again, this is my opinion, the doctors that tend to be more money focused tend to be male, and the doctors that tend to be less money focused tend to be female. Again, there are always exceptions to that, but I don't know. There seems to be some association between greed and testosterone. So I don't know. I don't know if there's been any studies on that. But I'll move on to the next question. What are the longitudinal trends in fee-for-service versus value-based care? Is value-based adoption growing or contracting? That's a great question. Appreciate that, Shiloh. I think the answer is that it's fits and starts. And in terms of the government being such a large payer for healthcare, that frankly, Medicare and CMMI, the Centers for Medicare and Medicaid Innovation, have actually walked back and are sort of sunsetting a lot of their value-based care programs because, frankly, they were found to not work. They were found to not save any money. So now it depends on who you talk to. That's my view. Now there'll be other people that you talk to that say, okay, yes, value-based care is growing. I would argue that, again, don't listen to what people say. In order to validate that, you have to literally look. It's almost like a forensic accounting activity. You'd have to literally do what these researchers did, and you'd have to not listen to what people say, but you'd have to look at literally the amount of money that was flowing, the number of doctors that were receiving that money, instead of like you can't judge it based upon the quote unquote program. Like, you actually have to base it on the dollars. Okay. Next question or comment. Thank you for that, by the way, Shiloh. How do we get there to be more transparency in the PBM? Okay, you're asking PBM questions. Wonderful. Let me go through topic number 2, the PBM money flow. Okay, now, this chart right here, again, comes from it's an academic journal. It's actually from the Journal of Clinical Oncology, and it was about the role of pharmacy benefit managers in expensive medications to treat cancer. And so this is not my chart. This is from the Journal of Clinical Oncology. Now, I would argue, so I've seen, I'm sure many of you have seen as well, many different charts sort of explaining the PBM money flow. I would argue that this is actually the most straightforward chart that I have seen on it. And I would argue that if you work in health insurance and healthcare and health benefits, that you need to be able to reproduce this chart on a napkin from memory, right? So if this is a training session, and if I was going to have a test after this training session, the test for this section of the training would be, okay, draw the PBM money flow. Okay, so when you draw this, you're going to start out by drawing the boxes. Okay, and what you're going to do is you're going to start at the top. And because we're talking about prescription drugs, you're going to put the pharmaceutical company at the top. And then you're going to draw 2 columns on the left and the right. Now, at the top of the upper left-hand corner, you're going to put the PBM, which makes sense, right? Because when we read a page on a paper, we start in the upper left. So just know that you're going to put the PBM, and then you're going to put the plan, the employee health plan, and then you're going to put the employer/government. So I just abbreviate that PPE. So it's the drug company on top, and then the left-hand column is PPE, PBM, plan, employer. Now, in the left-hand column, you're going to put the wholesaler, the pharmacy, and the patient. So it's WPP. So it still has 2 P's, but the P's are at the end. So we're talking about medications. So drug companies at the top, and then it's PPE on the left and WPP on the right. Fantastic. You've got your 7 boxes. You've got to start with your 7 boxes. Okay. Now, then you start where the money starts. So where does the money start? The money starts with the employer/government. Okay. And you're going to draw an arrow because the employer gives the money to the plan. Now, the plan is a distinct entity from the employer because, remember, the majority of employees in America are on self-funded plans, and literally the self-funded employee health plan is a separate legal entity. Okay. It is not the employer. It's actually the plan. Okay. Now, the employer is the sponsor of the plan. In other words, that's why there's an arrow. That's why there's the money going from the employer to the plan. Likewise, it could be a union, right? And that union could have a whole bunch of different employers that are paying in to that union plan, okay? Now, the plan then pays the money for the drugs to the PBM, okay? So all the money for the medications goes through the PBM. That's the choke point, okay? And then you see the diagonal area. Then you have to switch over and go over to the right-hand column. And then the PBM pays the pharmacy. Then the pharmacy pays the wholesaler. You think of it like a huge warehouse, right? So there's 3 big medication wholesaler companies in America. McKesson, which is the largest, AmerisourceBergen, which is the second largest, and Cardinal, which is the third largest. So you can think of them as like the big warehouser and distributor of the medications. And then the wholesaler then has to buy the drugs from Pfizer, Merck, AstraZeneca, GlaxoSmithKline. You get it. So then the money goes to the pharmaceutical company. So you see all these arrows, and what you want to do is you want to create that your main path starts in the bottom left, goes employer plan, PBM, comes over to the pharmacy, goes up to the wholesaler and to pharma. Okay, so that's the direction of the money flow. That is like 90% of the money flow. That's like if all you get on this chart is that, that's super. I'd give you 90% credit on the test. Okay, now, where's the patient in this? Because the patient pays money as well, okay? So the patient has to pay the pharmacy, right? Because you got to pay your copay at the pharmacy, or if it falls under deductible, you got to pay the deductible amount at the pharmacy. And then the patient also has to pay a portion of their premium to the plan, right? So most employer plans are anywhere from 30 or about 10 to 30% paid for by patient employee premiums. Okay, so the patient's paying 2 places. They're paying part of the premium to the plan, and then they're paying to the pharmacy it's the out-of-pocket cost. Okay, so that's your second group of arrows. So your first group of arrows is the overall money flow, and then your second group of arrows is from the patient. And then your final arrows is how the PBM is then compensated by the pharmaceutical company. So the pharmaceutical company pays the PBM. Okay, so if the pharmaceutical company, what's that relationship called? What's it called when you buy a stock through a stockbroker and that stockbroker gets paid? That's called a commission. When you buy a house through a realtor and the realtor gets paid, what's that called? It's called a commission. When you go to a car dealership and you buy a car from the salesman and the salesman gets paid, what's that called? It's called a commission. So the PBM and the pharmaceutical company don't call it a commission, but that's what it is. It is a commission. Now it has other names to it, right? And the biggest name is a rebate. And they call it a rebate because they're like, okay, well, we'll give you, it's like cash back on your credit card. Okay. Well, nobody thinks that they can actually save money by buying more things on their credit card through cash back. You're like, I'm about to go broke. I should buy more things on my credit card because then I'll get more cash back. Like, nobody thinks that. Okay. Obviously, the math does not work on that. You will only accelerate how quickly you go broke if you try to make money through your credit card cash back. All right. Now, but the problem is that the red arrow is the cash back. The red arrow is the commission. Now, does the PBM give some of that commission, even the majority of that commission, to the plan? Of course they do, but they keep a significant amount. That is their commission. Now, the pharmaceutical company also pays the PBM for formulary placement to get preferential placement on the formulary of the PBM. The pharmaceutical company pays them for that. The pharmaceutical company also pays administrative fees to the PBM. The pharmaceutical company also pays bonuses to the PBM. The pharmaceutical company also pays what are called market share payments to the PBM. In other words, if the PBM can get a certain benchmark market share for a particular medication, then the pharmaceutical company will pay them extra for achieving that goal. Okay, so just know that PBMs are paid a commission by pharmaceutical companies. You can call it whatever you want. Again, it's a free country. You can call it a rebate. You can call it an admin fee. It is a commission. All right, now you've got some questions and comments here. Let me go look here. Thank you for these, by the way. All right. I'm sorry. I'm just reading through here. I apologize for my silence here for a minute. Sonia, thank you for summarizing my PPE and my right side WPP. There you go. You got it. Sonia, you get 100%. What position, this is a question from Ronalyn, thank you so much. What position do health insurance companies have in value-based care? Okay, that's going back. Let me go back to that for a second. I will answer your question. Thank you, Ronalyn. How do pharma savings programs fit into all this? Okay, now, for the sake of simplicity, I did not literally put all of the arrows on here. There's a few more that I left off. And that specific pharma savings program that you're talking about here is where essentially there's an arrow that goes from the pharmaceutical company down here to the patient, because essentially a prescription assistance program is essentially a pharma subsidy to the patient to subsidize this arrow right here. So it doesn't occur for all drugs, doesn't occur for all pharmaceutical companies, but for a lot of expensive medications, there's an arrow that goes from here down to the patient to subsidize this arrow and reduce this arrow here. Now, that subsidy doesn't literally come in the form of a check to the patient, but that subsidy might come around here, and so therefore just negate or cut off, if you will, this arrow here. So thank you for that question. Now, Ronalyn, let me go briefly back to your question. What position do health insurance companies have in value-based care? Do they support it or want it? Yes. So so great question. Again, the health insurance companies claim that they are moving away from value-based, from fee-for-service towards value-based care. And I have a whole AHealthcareZ video where the CEO of Blue Cross Blue Shield of Arizona specifically says that at the end of the day, only 50% of provider contracts with health insurance companies have any sort of value-based component in it, 50%, and only 10% of the actual compensation in those 50% of employers that have quote-unquote value-based care contracts is value-based. Only 10% of the reimbursement is value-based. The other 90% is still fee for service. Okay, so to get the full dollar amount that's in value-based care, you would multiply the 50% times the 10%, which means that only 5% of commercially insured payments to doctors and hospitals from commercial insurance companies is quote-unquote value-based. Thank you for that question. Okay. Next question here from Ross. Thank you. Can you show where GoodRx and Mark Cuban fit into the schematic? Okay. So GoodRx is only for cash pay. So this entire employer plan part over here does not apply to GoodRx. GoodRx, believe it or not, is just a marketing company for PBMs. The discount that GoodRx is able to accomplish is because on the back end of GoodRx, so GoodRx like gives you this number that you give to the pharmacist, and that number then gives you a quote-unquote better price than the pharmacy cash price. It's because GoodRx has negotiated, I shouldn't say negotiated, it's just the front for PBMs, so that the pharmacy, which would typically charge the patient more, then has to run the pricing through the PBM. And again, the PBM gets a cut as a result of that. So the pharmacy really doesn't like GoodRx because, one, they can't charge the patient as much, and then two, the PBM gets a cut of that revenue because it was run through the PBM. And so the PBM then pays GoodRx part of that. Essentially, the PBM pays a commission on the commission, right? So the PBM is getting a commission, and then they're paying some of that commission to GoodRx because they are a marketing firm for the PBM for people who would normally have to pay higher prices for cash price drugs at the pharmacy. All right, now on to Mark Cuban. So for Mark Cuban, what he's doing is he's essentially saying that he is the wholesaler and the pharmacy. Now, he doesn't have physical pharmacies. It's only mail order. Okay. And what he's saying is, and he is incorporating the PBM as well. So what he's then saying is that all of these 3 boxes right here are going to just be the cost of the medication plus a transparent amount, because the amount right now that the pharmacy gets, the PBM gets, and the wholesaler gets is hidden, and it's up, for things like insulin, it's upwards of 30, 40, 50, 60% of the total cost of the medication is actually not what is coming from the pharmaceutical company, but it is through these 3 agents. And so what Mark Cuban is doing is he's combining these 3 agents, and he's basically taking all of their margin that they're normally charging, and they're saying, hey, my cost plus is my margin for replacing these 3 entities, and I'm going to make it transparent, and I'm going to tell you what it is. So without getting too long-winded, I probably am too long-winded already. That's how it fits in. Okay, I'm going to keep moving on because we're at the 40-minute mark, but thank you for all your questions. Topic number 3 was the One Medical acquisition by Amazon. So One Medical is 188 primary care clinics across America in 17 metro areas. As you can imagine, it is really the 17 largest metro areas in America. So you got New York and LA and Chicago and Dallas and Houston and Atlanta, et cetera, et cetera. Now, they were bought by Amazon for $3.9 billion in July of this year. Now, interesting, a lot of people on first glance would say like, oh, $3.9 billion, that's a ton of money. One Medical must be super happy with this. And I would argue that One Medical was not necessarily super happy about this. And the reason is because One Medical was a publicly traded company, and One Medical was sold at that to reach that $3.9 billion purchase price by Amazon. They had to buy it off the public market, and now One Medical is no longer a publicly traded company. And they bought it for $18 a share. Now, at its peak, One Medical had not IPO'd too long ago. At its peak from its IPO, One Medical reached $60 a share. So it was down almost 70% to $18. Now, the reason why Amazon was able to get away with $18 per share is that it had dropped even lower than $18 per share. So it's like $16, $15, $14, $13 a share. So the Amazon bought One Medical at a premium over its current, stock price at the time. However, One Medical's stock price had been tanking. I mean, if you had invested in One Medical when it was at its zenith of $60 per share, you lost gobs of money. And let's say you held on to it all the way to the bottom, right? And let's say you're like, well, listen, I think it's going to make its way back. And believe me, of course, all the executives at One Medical were working like mad to try to get it back above $60 as well. And then you as a shareholder were forced to sell your One Medical stock at $18. So you were basically forced to lose money in this deal. Now, let's break down One Medical's business. They actually they contract with employers to provide primary care services. Now, interestingly, it's still fee-for-service primary care, but they're like, oh, well, we've got, all of these services and we take more time with the patients and we do more preventative care and we keep people healthier and we keep them out of the hospital and we treat their chronic conditions better. And listen, all that might be true and they might do all those things. And so and then they also do that for individual consumers. You can just sign up for One Medical yourself. Now, 95% of the 700,000 patients that One Medical clinics see. So One Medical sees 700,000 patients across those 17 geographic locations. 95% of their patients are part of that arrangement. They either are just a consumer that signed up for consumer medical on their own, or they got it through their job. Now, that 95% of the 700,000 folks represents 50% of One Medical's revenue. Okay, isn't that interesting? What's the other half of One Medical's revenue? It is from Medicare Advantage. 5%, only 5% of One Medical's business are Medicare Advantage patients, where the Medicare Advantage plan, again, it's a commercial insurance company. It could be Humana's, it could be United's, it could be some other Medicare Advantage plan. That health insurance company pays One Medical a global capitation amount of, let's say, $15,000 per beneficiary per year. And whatever the total healthcare costs for that person, hospitalization, specialist care, surgery, et cetera, it comes out of One Medical's pocket. So One Medical is fully at risk for those Medicare Advantage patients. Now, that financial arrangement is totally different than the consumer and employer financial arrangement for One Medical. The financial arrangement number one, remember, is just fee for service. Financial arrangement number two is capitation, or quote unquote value-based care. Note that the capitation value-based care is 50% of One Medical's revenue off of only 5% of their patients. How is that possible? Well, that's possible because those capitation payments from the government to the health insurance company and then from the health insurance company to One Medical are huge. I mean, what thing in America does a person spend $15,000 a year on? It's like their rent or their mortgage, and then like healthcare is number two. You don't spend that much on food. You don't spend that much on gas. Like, it is like the number two cost for seniors. Not borne by them, but in terms of like what's being spent on them. So there's gobs of money in Medicare Advantage. The economics of Medicare Advantage are huge. One Medical didn't create that business. It bought that business. It bought a company called Iora. Now look at this here. The purchase price of Iora. So One Medical went out and they bought Iora in June of 2021. So essentially a year before the Amazon acquisition, was $2.1 billion, which essentially you can think of it as, okay, Amazon bought two businesses. It didn't buy one. It bought two businesses. It bought Iora, let's say, for $2.1 billion. And then it bought One Medical for $1.4 billion. So in other words, it paid 50% more for Iora than it did for the actual One Medical employer consumer facing folks. So what does this mean? When we think about Amazon wound down its Amazon Care, like virtual, like telemedicine solution, it wound that down that they were selling to employers. That does not exist anymore. Now, when in buying One Medical, they are the majority of their purchase in One Medical was to get into Medicare Advantage. So in my interpretation of this acquisition, this is more a play for Amazon to enter Medicare Advantage than it is for Amazon to enter the employer space. This is more a Medicare Advantage play for Amazon than it is. And it makes sense, right? Because Medicare Advantage is the cash cow for United and Humana and Anthem, Elevance. So like the future of private industry, of commercial insurance for Healthcare is in Medicare Advantage. That is where the huge growth and the gobs of money are. So I want to put that Amazon acquisition in the context of Medicare Advantage. That's a very important point, in my opinion. All right. Now, the fourth and final topic is another acquisition. It is the Change Healthcare acquisition by UnitedHealth Group. Okay, now, what is Change Healthcare? Most people have never heard of this company before. Now, Change Healthcare, first of all, it didn't used to be called Change Healthcare. It was only recently called Change Healthcare. A few years before, it was called Emdion. And it had been called Emdion for the vast majority of the history of the company. And only recently, what did it acquire? Emdion acquired this really small company called Change Healthcare. And then Emdion changed the name of its company to that very small company that it acquired. So Emdion / Change Healthcare processes $1 trillion worth of claims every year. It's the electronic claims clearinghouse that doctors and hospitals send their bills to in order to then get paid by Blue Cross United, Cigna, Aetna. So, St. Joe's, St. Mary's, St. Barnabas, whatever, Dr. Joe, Dr. Smith, they all send their bills not directly to the insurance carrier. They send it to Change Healthcare / Emdion. And then Emdion has then electronic connections to the health insurance carrier so they can then parse it out to the right carrier that it goes to. So now, $1 trillion in claims is about 25% of all U.S. healthcare spending. They do this for 5,500 hospitals and 800,000 doctors. Okay, there's about 1 million doctors in America, so they do it for 80% of all doctors in America. Now, this acquisition was originally announced in January of 2021. So here we are, almost 2 years later, talking about it. And the reason is because the Department of Justice and the New York and Minnesota attorneys general sued to block the UnitedHealth Group acquisition of Change Healthcare on antitrust grounds. And a court recently, a federal court who was, again, this was decided by a judge. This is not decided by a jury. This one judge. So just know that the judicial system in healthcare is incredibly powerful, because literally this one person said, I think it's okay for United to do this. And we're going to get into his rationale for why. So it was a $13 billion purchase price just in September, so just a handful of months ago, and the transaction went through. So Change Healthcare is now owned by United. Now, interestingly, Change only had $3.1 billion of revenue, which essentially, United bought Change Healthcare for over 4 times revenue. Like that's a lot of money. Now, one might argue that that's too much. One might argue that that's not enough, but that's a lot of money, 4 times revenue. Now, UnitedHealth Group, it got cut off here, makes $288 billion of revenue. So United is not trying, in my opinion, to increase the value of their company by increasing the through acquisition its revenue, because adding $3 billion to $288 billion is less than 1%. Like, keep in mind that if you look at United's revenue growth, it's a drop in the bucket. Like this doesn't even move the needle in terms of, like, if I'm not a United shareholder, I own an S&P 500 like index fund. I'm not even happy about it, but I do not own any direct United stock. So if I was a United stock owner, like, I would be like, I'm not sure that this acquisition actually adds value to me as a shareholder, because you paid $13 billion for something that's not even going to increase your revenue by 1%. Okay. So in other words, it's not the revenue or the margin isn't the reason why. It's because of the strategic position that Change was in, because it has access to those $1 trillion worth of data. It's got all the data. United paid $13 billion for data. United paid $13 billion for data. Wow. Why is that a problem? ProPublica released, which is the investigative journalism. Interesting. ProPublica it's a not-for-profit investigative journalism organization. It doesn't sell money through advertising, and they did an investigative report that they published on November 16th of this year. You can go and read it yourself, where they found out that United hired the consulting firm McKinsey to assess this potential acquisition before it happened. To be like, hey, we're thinking about making an acquisition of Change. McKinsey, we'll pay you lots of money to tell us what you think about this acquisition and how we could strategically use it. And McKinsey says you can, because keep in mind, Change Healthcare has all of the data, not only for United, but they also have it for Blue Cross United, Cigna, and Aetna. They have it for United's competitors. So because United now owns Change Healthcare, United now has access to competition's claims data. And McKinsey even recommended you can use your competitors' claims data to make better plan designs at United. Aha! That's a problem. So United knew this was a problem. United, in the court case, tells the judge, we just won't do that. We hired a consulting firm to tell us how we could strategically use Change Healthcare's data, and we're not going to do that. And we just promised to not do that. And the judge was like, I believe you. That essentially was the grounds for the judge allowing this, is to say, okay, yeah, it would be a problem if you used Change Healthcare's data on the United Health Insurance side to change, make better plans designs. But I trust you that you're not going to do that. And, United's point was that we're an incredibly trustworthy company, and that we've got a firewall between, Optum's actually owned by, Change Healthcare is owned by Optum. And so that we've got a data firewall between Optum and Change Healthcare and United Healthcare Insurance. We will not share that data in between, and you can trust us on that. And the judge said, okay, we can trust you on that. And that's fine. It just takes me back to the old comment of, you got to trust but verify. Okay, fine. You trust United. What's the verification process? How do you know you can be trustworthy? The point of the ProPublica article was United has had issues of trust in 2022, 2021, 2017, and 2008. So the ProPublica argument is that United has trust issues that have happened in the past. How do we know that United will not have trust issues going forward, when trust me is the main argument for why this suit or why this merger should be allowed to happen? Now, it's not over. The Department of Justice and the attorneys general for New York and Minnesota are appealing this. So even though the transaction has gone through, it is being appealed. So we're just going to have to see. Now, in summary, what I want to see, what do you take away from all this? So these were the topics that were most popular among viewers of AHealthcareZ in 2022. What do you take away from this? Listen, money for docs, money for medications, money for market entry in the form of Amazon entering the Medicare Advantage market, and money for middleman expansion, which is essentially what the United Health Group acquisition of Change Healthcare is. Those were the most popular topics. Money for docs, money for meds, money for market entry, and money for middleman expansion. The take-home point is that there are misaligned incentives that I have outlined here, and those misaligned incentives in 2022 have frankly become more entrenched. Okay, so just know that the one of the main culprits of high cost, low quality, poor access to care in America is the misaligned incentives of the organizations in healthcare itself. And those misaligned incentives are misaligned for the patient. Okay. They're not misaligned for the people who are misaligned. I mean, the people who are misaligned like the fact that they're misaligned, but they're misaligned for the patient and what's best for the patient. Okay. Now, gobs of people are working to change healthcare. Many of you on this training session are working to change healthcare, which is fantastic. What we're working to do is we're working to reduce, remove, and eliminate these misaligned incentives for the sake of patients. I view this as a public health threat. The misaligned incentives in healthcare are like dirty water and contaminated food and mosquitoes carrying West Nile virus, okay? The misaligned incentives in healthcare are a public health threat. And so I look at all of you and myself as, frankly, as working in public health. That's what we do. We work in public health. Like, this ultimately is not about money. Like, this is ultimately about public health. But the problem is that the way that money is in healthcare today is like West Nile virus. I'm like, okay, like and I've seen this, like West Nile virus can paralyze you. Like, I've seen patients who like can't walk anymore because of West Nile virus. And we're like, okay, you can't walk anymore. We probably need to do something about these mosquitoes and West Nile virus so that you can walk. Okay, and you can try to treat the person with West Nile, but it's much more effective to like do mosquito minimization campaigns to like get rid of standing water and spray for mosquitoes and all yada, yada, yada. So that's what we're doing here. We're trying to spray for mosquitoes. Okay, now, change within healthcare becomes much more prevalent and much more common during economic recessions. So we may be headed towards an economic recession. There is a lot of employer complacency around how they spend money in healthcare. And it's only the pain of a recession that snaps the employers out of their complacency to then change the way they're spending their healthcare budgets. A way to improve the misalignment in healthcare is to change the way the employers are making their budgetary decisions around healthcare. Those changes in budgetary decisions don't typically happen until there's a recession. I've got an AHealthcareZ video where I point out how major changes in healthcare have coincided with economic recessions. So I'm not saying for sure that we're going to have a recession. I'm not saying for sure that we're going to have change as a result of a recession, but I'm just saying that in the past, the probability and the extent of change within the healthcare system has correlated with recessions. So with that, I want to thank you all for being here today. I want to wish you a happy holidays, a Merry Christmas, a happy Hanukkah. I want to wish you health. I want to wish you safety. And I'm just super appreciative of everything that all of you have done and your attendance. And again, I'm going to do these video sessions in 2023. So we will continue the training next year. And I look forward to seeing you then. Thank you so much.